two dilemmas here. One is that what I call the biggest problem, I think, in orthopedic stuff for the emergency department is X-ray negative orthopedics. X-ray positive orthopedics is really simple stuff. You know, one bone in one county, the other end of it in another county. You don't miss that. Maybe it's a problem for somebody else down the road, but those are the easy ones. The tough ones are where it's X-ray negative and it's important that you not miss it. And so scaphoid is the one that has those characteristics because, as you remember, the blood supply to the scaphoid comes from distal to proximal. So a fracture across the waist of the scaphoid can interrupt the blood supply. The proximal part of the scaphoid, if not immobilized, and actually even if immobilized, gets aseptic necrosis. And then they get bad radiocarpal arthritis. So some guy who works as a painter for the living or a construction worker has a bad radiocarpal arthritis from missing an X-ray negative injury. So that's why we have a lot of anxiety about this, is that it's easy to miss and it's important, one. A lot of other small fractures, if we miss them, big deal. You know, a little radial head fracture, if you miss it, so what? You know, there's no real bad outcome. This has that. The other part of the dilemma is that the literature on this is all over the map in terms of what to do, how to diagnose it, that sort of thing. So as of 1992, there were over 300 articles published on this. So that was only as of 92. And there's 30 articles in here, and they're somewhat all over the map. I think, even though I have a lot of problems with a lot of the methodology in this, and I'll get into some of that in just a little bit, I think we can get enough take-home messages to learn something from all the articles here. The biggest problem with this is, again, the gold standard that I've talked about before. So what's the gold standard for a scaphoid fracture? Is it follow-up at 6 weeks and you see it on an X-ray? Is it follow-up at 6 weeks and they're still clinically tender even though their X-rays are negative? Is it a combination of those two? Is it an MRI? Is it a CT? Is it a combination of those two? And it gets muddy because in anything where X-ray is used in the whole evaluation, you get operator dependence. Some radiologists can see it, some ER doctors can see it, some orthopods can see it, and others don't. They don't agree with it. So that makes this whole mix almost impossible to figure out sometimes, and I'll point out a lot of these things as we go. So the first issue becomes, how about just clinical exam? They fall on the outstretched wrist, they're tender over the scaphoid. How good is that for either including or excluding a fracture? No good at all. You know, they can be very tender and no fracture, not too tender and have a fracture. That's about as good as you can get from the first couple of articles here. The one, they said, the scaphoid tubercle, the proximal portion of the scaphoid, if that isn't tender at all, they don't have a fracture. Well, that's sort of like if it doesn't hurt at all, why were you thinking of it to begin with? So not too much to learn from that to try to separate out that. So other people have talked about, can we do some sort of diagnostic maneuver, one where you put them in ulnar deviation and then rotate, and then put them in radial deviation and do all these kinds of things. And if all of those are negative and they don't hurt, they don't have a fracture. Right, again, you're saying there, why were you thinking they might anyway if nothing hurt? So, and it wasn't perfect either. So how reliable are plain X-rays both initially and follow-up patients with suspected scaphoid fractures? Again here, the whole question becomes operator dependence. There's a number of studies in here that will show they didn't have a fracture when you saw them initially, and then you follow them up and they're still tender, and now you see a fracture line. And a bunch of those then go back and look at the initial X-rays and say, what was there initially? You just missed it. And other people will say no. So not very good. There's an opinion piece here, number 6, a British opinion piece, says, you know, if you take everybody and immobilize them, then a lot of people lose an awful lot of time from work with a cast on their hand that don't need it. An average number here is maybe 20% of the people that we see and immobilize will actually have a fracture later, somehow diagnosed. It's a rough number. We'll get into some others that are more specific. But he says, so 4 out of 5 don't need it. They'll miss time from work. That's a lot of money. That's a lot of time lost. And we're immobilizing all these people. I think the biggest time when that becomes an issue for me is especially if they have another injury that you're going to immobilize. You know, you tie up 2 hands in somebody, how are they going to get dressed? How are they going to go to the bathroom? I mean, it really becomes a practical issue. How are they going to manipulate their crutch for their ankle when their hand has now got a cast on it? So I think there is some reason to think sharply about whether we can not immobilize some of these people. There's a New Zealand paper here that just to use about how all over the map it is. They said they virtually never found anybody in follow-up that had a fracture if they didn't diagnose it initially. So this isn't a problem. We don't see that kind of stuff. That's at odds with most of the literature. The next set of articles, people, I think this is a lot of times when you need to publish an article to get out of your residency or to do something else, is inter-observer agreement. So if you show the same x-ray to a whole bunch of people, how many agree on what the findings are? And in almost all of these, inter-observer agreement is poor. A kappa of less than 0.4 doesn't look good. So that's what we all know, is that different people will read these differently. I think ER docs tend to read that film based on what they know of the clinical exam, and that's the way we do a lot of those things. Radiologists tend to look at things otherwise. I think the take-home message from that in this, as it is in some other things that I'll give you an example for, is to just tell the patient that. There's nothing worse than you saying it's a wrist sprain and your partner the next day calls them back and says, oops, it's broken. I think the patient doesn't realize what the radiologist looking at the next day is something finer than a hair in terms of the fracture line, when I think most patients think of a break as like you take a pencil and break it in half and there's 2 pieces of it sticking up there and somehow the dumb ER doctor didn't see that kind of thing. So I think it's best to just do what I call the preemptive strike. Say, look, these things are read variably by a lot of people. The study that I love best on radiology, and I'll divert to this for just a second, the best ever is on pediatric pneumonia. And Mayo Clinic, we all bow to the Mayo Clinic pediatric radiologists, they get a chest x-ray on a kid with cough and fever, and they also get some on like pre-op chest x-rays on kids just to get a pre-op. And then they ask, how many see a pneumonia? And they say, okay, I see a pneumonia, it's right lower lobe, and they don't agree with each other all that much. There's some disagreement, I don't know, like 25% of the time. Then the beauty of x-ray studies is they take the same x-rays and show them to the same radiologist 6 months later, and they disagree with their own initial reading like half of the time. Even when they agree with their initial reading, somehow the pneumonia switches sides. Said, oh, I thought it was right lower lobe this time, now I think it's left upper lobe. You know, so that is my ultimate example of how this is just an opinion when someone looks at subtle radiologic findings. Obviously, for the gross ones, we can all agree on those, but almost all the times the navicular findings or the scaphoids are fairly subtle. So then the next, the next group of people talks about, how about using a more advanced imaging technique for the gold standard, like MRI? So what is MRI best at? You know, one of the hard things about getting your mind around what an MRI does is that it doesn't follow any principles that we know from physics commonly. You know, with a CT, if there's a plane and the beam is not in the plane of the image, you might not see the fracture, that kind of stuff, or if there's things in the way or how strong the beam is to penetrate. Those all somehow make sense because we translate that from a regular x-ray. With MRI, it's how the protons are spinning. And there's nothing in your usual experience that tells you why the proton should spin some different way based on how much water is in this thing. So it doesn't have a common sense notion to it, but I think the general principle of MRI, especially versus CT for imaging in bone, MRI is probably better for cancellous bone, the center of the bone, the marrow, and CT is probably better for cortical bone. So actually when you look at spine, say, CT is actually better at looking for fracture that crosses the cortex, but MRI is probably better at looking at something that involves the central portion of the bone or the swelling around it. So which is better? Well, Depends on where the fracture is and what you're going to see. So in a lot of these, that's what muddies the story here. But number 9 is actually one to point out. They had MRI as the gold standard. They took 50 patients who had either negative or questionable x-rays, and they said only 2 of the plain films were correctly interpreted by all the specialists in the study, and 13 patients were all agreed that were negative, but the MRI was positive. So they said that a variable interpretation of initial x-rays, again, says what everybody else does, that we don't agree on those. 10 is in here from historical interest only. Joe Wackerly in '87 laid out the rationale that we've all usually practiced under, is that you might not see it initially, so immobilize it and wait and get another x-ray down the road. How many here have that? It's pretty much the way they practice. If they suspect it, they splint them, they get them somehow followed up and see and follow. How many are trying to do some more advanced imaging technique so that they get out of that dilemma of just putting a splint or a cast on everybody? Not too many. And what do you use? CT? Mainly because you can get it? Yeah, okay. All right. So what's the role of CT, MRI, and bone scanning in the diagnosis of scaphoid fractures? Well, it's exactly the issues that I laid out there. You would like to have a firm diagnosis early on in some people so that you don't have to splint them for a variable period of time, or a lot of our patients aren't going to get follow-up with an orthopod because they just can't manage it or they won't do it, whatever. So you'd like to have an initial diagnosis there firm. And so, let me look here. Oh, so even with that, 13 looked at senior surgical residents, hand surgery fellows, attending hand surgeons, and they were asked to look at advanced imaging techniques, and even on that, they didn't agree. So again, all these things are just an opinion. That's why this literature is more difficult to read than, say, if their lactate is above 2 or not. You know, that's easy. We know what the number is there. These are an opinion by some people. So the other issue that comes up with doing advanced imaging techniques is one that you think we're lecturing on scaphoid fractures. In some of these studies, when they do advanced imaging techniques, over half of the fractures that they find are not in the scaphoid. So we've always known that you know, you fall on your outstretched wrist, and we're always worried when they're tender in the snuff box, but they can have other things, distal radius fracture, other carpal bone fractures. And so that's been one of the arguments for getting early on advanced imaging, is that you'll pick up these other injuries. And so once you look at that literature and say, you know, half the time when they suspected scaphoid, they found another fracture, it makes you rethink all of the plain x-ray literature that basically just looked at, did they have a scaphoid fracture at follow-up or not? Muddies the water anymore. So the gold standard again comes up, and with the early studies on this, people used bone scan as the gold standard. How many here can get a bone scan at their hospital? Right, not many, maybe. And so I think for a lot of places, it's a test of historical significance only for things. And then at least when I talk to my orthopods, if the bone scan is positive, what do you need to do? Get an imaging study like a CT to find out what the fracture line is like so they can decide whether they need to operate or, you know, that kind of stuff. So it's never the definitive test, where in a lot of the British ones here, they use bone scan as the gold standard. Like number 16, just to sort of get back to some of this methodology issue. They used bone scan as the gold standard for fractures. And then they concluded that bone scan is a reliable means of evaluating patients with scaphoid fractures. Well, of course. You've defined it as the gold standard, so of course you're happy with it. That's the end of the line for you. So again, that's why this literature is kind of muddy. Incidence of fractures in the next one, 15%. That was fairly low. A 1995 British study saying that half of the scans were positive in people, just to give you the numbers that people have with things. Oh, so the other thing that comes out with looking at MRI, when you look at old studies versus new studies, Here they considered, this is a 2008 study, an MRI to be specificity of 100%. Magnet strength. You know, how strong is the magnet being used to look at the suspected fracture? And again, that's, I mean, I know that's an issue, and I've been talked to by radiologists who can explain from the proton spin in the water why that's the case. But all I can know is that they're better the stronger the magnet. And so when you look at old ones where they said the MRI might not be so good, maybe now that we have stronger magnets to do it, that's the case. And then, of course, if you're going to use MRI as the gold standard for it, you've got to go through that entire checklist of things. How many here can get an MRI from the emergency department sometimes? Yeah, and how many know which pacemaker they can or cannot have in order to have an MRI? I mean, there's like 2 brands and certain serial numbers, and it's more work to fill out the form for the MRI than it is to put a cast on their hand and send them to somebody else. It's really a tough thing if there's anything going on with that. 2020, they found a lot of non-scaphoid fractures. So a Scottish opinion piece, they go and look at what are the economic consequences of putting all these people in a splint or a cast who really don't have a fracture. And as I've mentioned in my other talks, when you do an economic analysis, you got to decide what are their assumptions, because they're taking the literature and they're saying only 1 out of 5 actually have a fracture, probably a reasonable number, how long you're going to immobilize it for, how much money they could make in the meantime. And they say it's cost effective using Scottish dollars, you know, to get an advanced imaging technique and not immobilize these people. So that's one opinion that's out there. What is a rational approach? I thought 24 was a nice opinion piece. 20 questions about scaphoid fractures. He had 20 opinions, but he didn't back up any of them. And then the last issue here is, how should we immobilize somebody if they actually have a fracture or we suspect that they have a fracture? And the issue here centers around basically 2 things. Should you do, if you do a short arm cast, should you put a thumb spica on it? Or should you do a long arm cast? How many here, if they do it, do something short arm? And how many here do long arm? Okay, not many, because I don't know why that got popular. Now that really takes somebody out of action, you know, when you put them in a long arm cast in terms of what they can do. So in terms of how good is it, there's several endpoints that people have looked at. One is clinical, non-union or malunion at 6 weeks, 8 weeks, 6 months kind of stuff. And then the other set of studies look at artificial ways to do this. They'll take a cadaver, they'll artificially break the scaphoid, and then they'll put them in some sort of device and try to move it around and see how that moves. Others, they'll do that at the time of operation, that kind of thing. And the results are all over the map. Some of them say no immobilization is good enough to completely immobilize the scaphoid, depending on how you look at it. But I think most of them went with the short cast with thumb spica was probably kind of as good as it's going to get. All right, so key points and recommendations to bring back a confusing set of subjects here. Clinical evaluation is not sensitive or specific. So again, we're left with a lot of people that we suspected and we can't tell. Plain x-rays are problematic depending on who's reading it. So I think, again, you got to tell patients that they may or may not have a different reading. The best advanced imaging technique, I can't get anything from the literature that says one or the other. I think CT is probably what we're going to wind up using just because it's available to us if you're going to do that. Immobilization, I think short arm cast with a thumb spica is probably as good as it's going to get. How many weeks of immobilization? I think you could go with that if somebody doesn't really need to use that hand for a while. But I think we're probably going to go more toward definitive diagnosis in people that we want to not do that on. And then we'll realize we're going to find a lot of non-scaphoid fractures is probably one of the rationales for doing something else. And that's about it.